Welcome to Ask the Experts. I'm Rebecca Johnson, the Director of Research for BCAN, the Bladder Cancer Advocacy Network. I'm honored to be hosting this evening's event where our guest experts will be discussing what we know currently about bladder cancer treatment and advancements, and answering questions that many of you submitted during the registration process. We received well over 100 questions from participants, and we will do our best to capture all of the major issues and concerns raised, but we apologize in advance if we don't get to your particular question. We hope that you will remain with us until the end of the program when we announce the 2023 Beacon of Hope Award winner, as well as the recipients of BCAN's 2023 Young Investigator and Patient-Centered Clinical Research Young Investigator Awards. BCAN was founded in 2005 by Diane Zapersky-Qualley and her late husband, John Qualley, after they realized just how little information was available for patients with bladder cancer treatments and how little was being done to research new and better treatment options. Their goal was to build an organization that focused on improving bladder cancer patients' lives while also increasing attention to bladder cancer research efforts. And today that is exactly what BCAN aims to do. Advancing bladder cancer research is a critical part of BCAN's mission, and we strive to do just that each year through our multiple research award programs. BCAN's research awards focus on funding innovative science and addressing gaps in research and funding the best and brightest researchers. And one way we do this is through our Young Investigator Award program that supports early career researchers and clinicians who want to dedicate their expertise and talents to a career focused on bladder cancer. Today's program not only provides an opportunity to have your questions answered by bladder cancer experts, but also provides BCAN with the opportunity to showcase our Young Investigator program, as both of the experts joining us today were past recipients of this award. Over the past 10 or 11 years, BCAN has made over 30 Young Investigator Awards, and tonight we will be announcing the 5 recipients of the 2023 Young Investigator Awards. It is because of support from people like you that BCAN has played a transformative role in increasing the support and resources available for bladder cancer patients and in funding research to help advance treatments. BCAN's research program exists due to generosity of our donors and people like you. So if you would like to help us continue to build and expand our research program, I encourage you to make a gift at beacon.org/researchfund. Your contribution will support individuals who are working to conduct better research, improve patient-focused care, and find new and novel approaches to diagnosing and treating bladder cancer. We thank you so much in advance for your generosity and support. And now it's an honor for me to introduce our guest experts, Dr. Tracy Rose, who is in our 2017 cohort of Young Investigators. Dr. Rose is a medical oncologist at the University of North Carolina Lineberger Comprehensive Cancer Center. Welcome, Tracy, and thank you so much for joining us.
Thanks, Rebecca. Glad to be here.
I'm also honored to welcome Dr. Philip Abash, recipient of a Young Investigator Award in 2018. Dr. Abash is a urologic oncologist at Albert Einstein Medical Center and a translational researcher at Fox Chase Cancer Center. We're thrilled to have you here.
Good evening, everybody.
Both Tracy and Phil are actively engaged in the BCAN community in many ways, and we're grateful to have them here with us today. Lastly, before we get started, I want to mention that you do not need to take notes tonight during the program. This video will be available on BCAN's website, beacon.org, in just a couple of days. So with that, let's get started. I'd like to ask you to start with both answering a couple of questions, general questions that I'll direct for both of you to respond to. And the first, if you could share an exciting development in bladder cancer research or treatment that you feel either has the potential to or is currently impacting patient treatment outcomes and lives for the better. How would you describe that? And I think Tracy, we'll start with you.
Sure. So, my answer comes with the medical oncology flavor, I think, because most of how I treat bladder cancer is by treating the whole body with systemic therapy. So that is sort of the line of where I go when I get asked such a question. But as we improve care, it's been a really exciting few years in bladder cancer because we've seen lots of new drugs and new mechanisms, and also moving earlier with kind of response rates we've never seen before. So, I think my answer to sort of exciting recent development in research comes in the sort of type of therapy. So historically, we've just used standard chemotherapy for bladder cancer, and then we had immunotherapy, and now we have this new type called antibody drug conjugates, which is basically chemotherapy attached to a protein that targets the chemo directly to the cancer or to a certain protein that cancers express. And so it's really kind of targeted chemotherapy. And because of that, we're seeing some really nice response rates, but also some really exciting research opportunities and some drugs coming out that are really targeted based on the patient's cancer and what proteins it expresses, and then we can take chemo and deliver it directly to the cancer. And so I think that that's where the field is starting to go in terms of systemic therapy. It's a really exciting time where we're actually probably going to start like really selecting therapies and potentially even in the first line kind of on what proteins or DNA expression we see in people's cancers, really actually seeing this personalized medicine that has taken a while for us to actually get to. So I think we're already saving lives with some of these drugs. The one that's approved is called enfortumab vedotin, but there's a number in the pipeline that are pretty exciting. So I think that would be my answer, sort of novel therapies and ways to deliver therapy better in terms of side effects and how well they work.
Thank you. And just to follow up before we hear your response, Phil, Tracy, when you talk about some of these novel therapies and antibody drug conjugates, is that for all patients at any stage or for advanced patients, or who specifically would those be appropriate for?
Yeah, I mean, right now there are only, we only have one antibody drug conjugate that's actually FDA approved, and it's only approved in the metastatic or advanced disease setting. But we've seen already some data for enfortumab given before surgery for muscle invasive disease. And as we, get these therapies to be more tolerable and work better, you can imagine them moving earlier and earlier in the course of treatment. But right now it's for advanced disease.
Okay, thank you. And Phil, same question. What would you say is an exciting development in research or treatment right now?
So I would say I sort of have a two-part answer to this. It sort of goes piggybacks on what Tracy mentioned. So the idea of biomarkers to assign a therapy to the disease that makes the therapy more likely to work. We are actually doing this already for patients with mutations in a gene called FGFR3, which is a really important growth signaling kinase in bladder cancer. So my two parts are biomarkers such as FGFR3 and then FGFR3 targeted therapies. I think those are, we use those sort of sparingly now, but my hope and my dream is that we start using those a lot more. Especially for patients maybe with upper tract cancers of the inner lining of the kidney and the ureter, and then also for some patients with either localized or metastatic bladder cancer as well.
Mm-hmm. And then that ties in well to the second question I'd like to pose to you both, and you might have just touched on it in your initial response, but we'll start with you, Phil. What is one area, or it can be multiple areas, that you think is a really critical research priority for bladder cancer right now? What do we need to know more about right now?
So I will stick with what I know. I'm a biomarker person. So our lab is developing urine-based biomarkers for patients with bladder cancer. I think the idea of using urine to either detect residual disease after a therapy or try to figure out which drug a patient needs to get for their therapy is something we're doing a little bit of now, but I really think we should be doing a lot more. There's a ton of opportunity to build those kinds of research clinical paradigms for treating patients. I think we do urine, but I think there's opportunity for blood biomarkers, tissue-based biomarkers when a patient has a biopsy. again, and those all could be used to direct the next line of therapy. And everybody sort of always points to breast cancer as sort of like the sort of like the golden child of targeted therapy with estrogen receptor, HER2, triple negative breast cancer, BRCA mutations. Those are things where you know what the tumor's makeup is, and the oncologist like Dr. Rose would give a therapy that's intended to knock out a tumor that has that defect. And so I guess that would be my answer. What I'm hopeful we see it more of is biomarker.
Yep, great. Thank you. And Tracy, same question. What do you think is the research priority right now?
Yeah, I mean, I think Phil is right in the biomarker answer. So I'll just change my answer because he already took that one. But I do really think that, figuring out what is the right treatment for the right patient, right? Avoiding over treatment in the people that don't need all that treatment, but then also not under treating the people that shouldn't be on surveillance or need more aggressive therapy, right? And we do this in pretty brute population-based ways right now. And really the answer for how to figure out who needs what, I think, comes from the science of the tumor and the person. And obviously we need to learn more about that. I think what I'll change my answer to, which kind of goes along with it, is, right now, as we develop new therapies or even new techniques for therapies, whether that be surgery or whatever, we tend to do these large trials, and especially with drug companies, they like to test it and everyone approve it works on a population level so that we order it and give it to everyone. But really that may not be the best approach from a patient-centered perspective. And, really, I think the research focus should be on sort of designing our trials novelly so that we can really test these drugs in the patients that need them to be tested in. And then also designing our trials to really help compare therapies, instead of having several single arm trial. Like, for example, we'll get into this, I think, later, but if you look at the non-muscle invasive bladder cancer space, we have a bunch of therapies that have been approved based on sort of single arm trials or some retrospective data, but we've never actually compared them. And so I think a research priority for the community is really coming up with studies that answer questions that really tell us what we should use for each patient. And I think, I think BCAN's a great place to develop a lot of these thoughts and concepts and research priorities.
Absolutely. Yep. Comparative effectiveness research is key right now for some of these new therapies. And I think you both touched on this in your responses that, bladder cancer presents very differently in different patients. Some may have non-muscle invasive, others muscle invasive, or even, advanced disease where it's metastasized to other parts of the body. And we might jump back and forth between them. But I do want to start with some questions about screening and then surveillance and recurrence, because we did get quite a few questions on those topics. And I think, Phil, we'll start with you. And you talked about urine already. Are there any other ways to detect bladder cancer other than through urine cytology or through cystoscopy?
So there are imaging tests. It's unusual, but sometimes people have a CT scan for some unrelated reason, like they had, vague abdominal pain, or they fell off a ladder, or were in a car accident, and lo and behold, they have a tumor in their bladder, or maybe in their renal pelvis, and that it sort of gets identified that way. That's not really a screening test. That's sort of just found incidentally. There are groups that are working on screening tests. I think the one that to me makes the most sense is a screening test that doesn't just work for bladder cancer, but maybe works for multiple cancers. So a company called Grail has something that's a blood test that detects, like, I forget how many cancers, but they say that it's sensitive to pick up a bunch of different kinds of cancers in early stages. And there's other companies that are working on stuff like that too. I don't think right now I think I've sort of spoken with them about they're interested in doing a urine-based test, but they're that's like very, or they're not anywhere close to having something like that ready yet.
And along those lines, are we close to having anything that would replace an annual cystoscopy?
Well, biomarkers. I mean, I think that's the idea. I mean, there are now again companies that are working on urine-based tests to maybe not completely avoid cystoscopy, but at least put it off, or maybe do less cystoscopy. I know everybody, nobody wants having their camera put in something that's meant to be a one-way street. But there are people that are working on biomarkers for cystoscopy avoidance.
Okay. And Tracy, once a patient has received a diagnosis of bladder cancer and they're working with a urologist, should they also see an oncologist immediately, especially if they have a personal history of cancer, and why or why not?
I think it depends on the situation. Certainly academic urologists and most community urologists, are pretty good at sort of the localized, non-invasive or early stage bladder cancer paradigm. Some rare bladder cancers are caused by what we call germline mutations, or sort of inherited predispositions to cancer, especially upper tract cancers. We see it relatively often. Actually, here at UNC, if you get diagnosed with an upper tract cancer, you automatically sort of get some protein staining to look for something called Lynch syndrome. But if there's a very strong family history, certainly either meeting with the medical oncologist or, even straight to a genetic counselor would be really potentially helpful. But a lot of the sort of localized bladder cancers don't really need a medical oncologist, at least at the beginning. Our role comes in once that cancer becomes more advanced or hits the muscle layer of the bladder, muscle invasive bladder cancer. So many patients don't meet with a medical oncologist. Obviously, all of us are always happy to meet with anyone that has certain questions. But sometimes I think if there was a specific concern about genetic predisposition or cancer history, genetic counselors are actually pretty available these days and do this all the time as we learn more and more about the genetics of cancer. And so that would be a good place to stop too.
Okay, great. And we know that bladder cancer has a high rate of recurrence. And Phil, first of all, why is that? Can you talk about why that happens?
Yeah, this is something my lab's kind of interested in. So there's something called a field defect. So we think that bladder cancer, well, we know that bladder cancer is caused by smoking, although it's not exactly like cancer of the lung that's caused by smoking. There's a little bit of a different genetic kind of fingerprint with tobacco associated bladder cancers than, say, tobacco associated lung or head and neck cancers. But what ends up happening is in those patients who smoke, the carcinogens in tobacco, inhaled tobacco, I guess byproducts, those carcinogens cause genetic alterations, mutations in all of the patient's bladder cells, the lining of the bladder, which is called the urothelium. And so some of those mutations are cancerous and some of them are precancerous. And so what we think ends up happening is a tumor forms, and then it's treated, and those genetic defects that were inherent in the bladder still persist in the normal appearing bladder. And so that reservoir of sort of pre-malignant cells can sort of grow out again into a second or a third or a fourth tumor. I think that kind of explains it for tobacco-associated bladder cancers. There's probably a similar phenomenon that happens in patients who don't smoke. There's probably other carcinogens that are excreted that we ingest, breathe, drink, etc. Those get excreted in the bladder, in the urine. The carcinogens affect the bladder. There's a field defect in the bladder as well from those carcinogens that again, a tumor may be resected, and then a second tumor kind of grows out from that pre-malignant normal appearing urothelium.
And one more for you, Phil, about recurrence, and then we'll kick it back to you, Tracy. If I'm a patient, I had a T1 tumor 10 years ago with no recurrence. How long do I have to have cystoscopies to check on this?
Well, if you were my patient, I probably would have stopped by now if you haven't had any recurrences in 10 years. I think, I mean, I definitely have patients like this where, I haven't been practicing for 10 years, but maybe 7 years. But at any rate, those patients, I sort of give them a little bit of a longer leash each time. And maybe they just come back and I say, have you had blood in your urine? Do we check a urine test? I think, in my opinion, it's probably overkill at 10 years. But, I think every patient and clinician have a different opinion on that at 10 years out. And so, I think I guess I would just suggest to that patient to try to engage in shared decision making. I think there's there's some benefit, obviously, to not having a cystoscopy every year. There's also some risk. And it really just depends on what the patient's and the doctor's risk tolerance is.
Right. So that's optimizing the treatment plan for the patient, specific to the patient. And Tracy, kind of on the opposite end of the spectrum, what about for a patient who's in their 5th recurrence, has already tried lots of treatments, including BCG? Is that maybe when they might see you, and what would some possible treatments be at that point?
Yeah, I think the answer to this somewhat depends on exactly sort of how high risk, if you will, their cancer is, right? Is this a 5th recurrence of a, tiny low grade cancer over 20 years, or is this sort of a high grade cancer that they've gone through multiple things and keeps, coming back? Because I think that those answers are really different. Still, if it's a, non-muscle invasive bladder cancer, sometimes they don't even need to meet with me, and urology will recommend either a cystectomy or another intravesical treatment. There is one FDA-approved sort of systemic therapy, immunotherapy called pembrolizumab for a very certain non-muscle invasive bladder cancer after BCG, if you meet all these other criteria. So sometimes I meet with these people, and that's actually a pretty recent, that's only been a couple of years since we've been seeing them on the medical oncology side. So I think it really matters sort of exactly what kind of recurrence this is, and how high is the risk of progression to a worse cancer or metastatic disease, and that really informs next treatment. I mean, if it's a high grade or high risk and someone's recurred several times, that's when urology will start talking about cystectomies.
And on that point, I'm going to stick with you for a minute, because you talked a little bit about immunotherapy, and we did get a lot of questions about that at multiple stages and types of bladder cancer. Can you provide a high level overview of immunotherapy? How does it work? How is it changing the standard of care and treatment? The loaded question, I know.
Yeah, it's actually it's a very much evolving field and evolving definition too. You could actually consider many treatments, quote, immunotherapy, depending on how you define it. But basically it's treatment that's intended to stimulate the immune system, which then will recognize a cancer as foreign. The immune system's job is to get rid of something in the body that's not supposed to be there. So you get a virus or a bacteria or a cell that starts growing uncontrollably like cancer, and your immune system's supposed to recognize it and get rid of it, right? And for whatever reason, bladder cancers can form and the immune system doesn't recognize it. And so actually, BCG, which is, used for localized bladder cancer put in the bladder, is kind of the first immunotherapy, and was like that. So we talk about it now as this whole new category, but in fact, it's been around for decades. And, the whole point of that is put this bacteria into the bladder, which then stimulates this immune response. And as the immune system reacts to the bacteria that's there, it gets recognized, gets rid of the cancer too. And so we've now developed therapies through IVs and even some subcutaneous that have the same effect. The most popular one's pembrolizumab, which I just mentioned, but there's a number of different ones. are actually antibodies that block some of the proteins that essentially are expressed on cancer cells or immune cells that allow the cancer to hide from the immune system. And so if you block that interaction, you can stimulate the immune system, and all of a sudden it'll recognize it cancer. So it's actually a very novel, it's very different than standard chemotherapy because we're using a person's own immune system to go after a cancer. And the immune system is an incredibly complex machine. And so there's a whole number of different ways. And actually, as we're learning more about our old standard chemotherapies, we're learning some of the way that those worked was actually breaking up things and stimulating immune response too. And so as the field evolves, it's a sort of an evolving definition too. But both BCG and some of the IV immunotherapies are really, centered on the same concept.
And we know that it's novel, and there's still a lot of research going on about immunotherapy, but is there a standard of care right now involving immunotherapy?
I mean, certainly there is in, the localized bladder cancer setting with BCG. And then certainly there is in the advanced bladder cancer setting, both now with an FDA approval for sort of after surgery for muscle invasive bladder cancer for certain patients with high risk features, but also, as a standard therapy for stage 4 metastatic patients. It's pretty much integrated into everybody's treatment, and many now kind of integrated in first line treatment, or at the very least, second line.
And I'm sure, Phil, we received a lot of questions about BCG, and a lot of patients are familiar with the fact that there is a shortage of BCG. Can you share any latest information about that, or its availability, and whether the shortage is going to improve?
Yeah, I haven't been able to give patients in my clinic BCG for like 6 years or something crazy. I personally don't, I think I'm not sure that BCG's come back. I think there's this hope that it's coming back. I've kind of lost hope, and maybe that's cynical or dark. I apologize if it's pessimistic. There are like sort of conspiracy theories about whether the drug companies want to bring it back because it's a very cheap, very effective method, and there are other methods that may be more financially lucrative for companies. Some of the ones that Tracy mentioned, and so whether you subscribe to those or not, I'm not sure. Of course, the drug company would never say that, but I don't see it changing anytime soon. I think the hope, I think the most likely hope is that there's other strains of BCG that people are trying to develop, and maybe those other strains might be as effective or more effective and available soon. But I kind of stopped paying attention because I think I've sort of resigned to the end of BCG here.
For patients that are still receiving BCG or received BCG, can you talk a little bit about some of the side effects that might accompany that treatment, or what they can expect? We received questions about, is long-term tiredness or fatigue a likely side effect? And what about nausea or pain with urination?
Yeah, the long-term effects I'm not so sure about. I think the immediate things, when I was a resident saying we were giving a lot of BCG that I was very familiar with, definitely, pain during urination, burning urination. That's called dysuria. You're putting a bacteria into someone's bladder that is, you're sort of giving them a bladder infection. So, the common side effects we'd hear about when patients are getting BCG were certainly burning, urgency, frequency. I feel like I have to go really bad. I go to the toilet and just, dribbles and drops come out and there's nothing there. That's certainly common. Very unusual to have, a systemic illness whereby I mean like a fever, or someone gets genuinely sick. That's called BCG-osis. That's pretty unusual. I would imagine you would feel run down, during the time of treatment. People probably have to wake up a lot at night to go pee. Can't go back to sleep. I mean, that happens a lot in patients who are, of the age where they're getting bladder cancer anyway, 60s, 70s, 80s. People wake up at night, and that I'm sure fitful sleep makes you fatigued. But the long term, I think if someone's having long-term pain with urination, long-term frequency, urgency, waking up at night, if that was not present before BCG, that would be kind of a surprise.
Okay. And Tracy, and either of you are welcome to comment on this, but Tracy, given that we are still experiencing a shortage of BCG, we know that patients may not be receiving the same course that they would had we not been in a shortage, or maybe not receiving maintenance courses. What do we know about the effectiveness of BCG treatment without maintenance versus with maintenance?
Yeah, so there's also there's a long answer to this question, but it's been somewhat standard to give third dose BCG at a lot of places, as well as in some of our clinical trials, because of the shortage, basically, sharing vials between patients, and then cutting maintenance short, trying to, we bucket non-muscle invasive disease into low risk, intermediate risk, high risk. And so trying to really save what BCG we have for the high risk patients. And then, but there's been studies that clearly show, rate of recurrence is lower if you give maintenance, and if you give maintenance for like 3 years for high risk disease compared to shorter. And we were basically forced to give it lower doses or lower amounts. That being said, some of the long-term sort of outcomes in terms of survival are not that different. And so, hopefully the community has really tried to make thoughtful decisions about who to preserve for and how to cut back in ways that we're not really compromising long-term outcomes. I'm happy for Phil to weigh in here, who actually doesn't give BCG, but probably has more than I have.
Yeah, so I think I would sort of piggyback on Dr. Rose's comment. So yeah, in places where they do give, BCG, where they still have it, Tracy's right. The centers will try to give 1/3 of the regular dose, and split one. What used to be one dose for one patient is now one dose for 3 patients. There's plenty of data that says that's as effective, or maybe almost as effective, as giving a full dose. It also probably reduces the amount of side effects that patients have. And then the other way, institutions will try to preserve the amount of BCG as Tracy alluded to, reducing the amount of maintenance BCG that's given. The reason for that is you get more bang for your buck by giving the first 6 doses of BCG. In other words, you're really changing the kind of clinical trajectory of someone's outcome by giving them any BCG. And then once you've got some BCG, the amount of benefit that a patient gets from getting, maintenance round number 1, maintenance round number 2, maintenance round number 3 is kind of a diminishing return. So the benefit after the first couple of doses is incremental. And so not having maintenance doses doesn't give you as much benefit as having the first 6 doses. And so that's a way to give more benefit to more people, without losing all of the benefit for some people, I guess is the way the Mr. Spock answer, the greater good.
Okay, thank you both. I know I'm sorry, Tracy, go ahead.
Yeah, I was just going to add, this is a little bit off topic, but it's on my mind because literally right before this, I came from a meeting because our hospital is running out of carboplatin and cisplatin and methotrexate, all of which are drugs used for bladder cancer, and all of which are generic and similarly don't cost nearly as much as some of the other options we have. And we're now rationing, including in bladder cancer at our hospital as of this week. So, this is not an isolated problem to BCG, and it certainly feels like it's getting worse in terms of supply and generic drugs. And I think it's, we're having to have some of these same conversations about, okay, we'll give cisplatin to the curative intent patients, but we can't give carboplatin to the metastatic patients at the moment is where we're at.
Yeah, and all of this really drives the point that we need more and we need better therapies in these shortages. And so, Tracy, you mentioned in one of your comments that there are different buckets of non-muscle invasive disease, higher grade or lower grade. And Phil, I wanted to ask you a question that we got about a specific type of non-muscle invasive bladder cancer, which is CIS, which we know is a higher grade and higher risk of recurrence that can appear like a patch or flat tumor. Can CIS be invisible, and can chronic cystitis hide patches of CIS?
Yeah, for sure. So CIS is notoriously difficult to detect by the eye or by the cystoscopic eye. That's why that's why people have developed like something like blue light cystoscopy, which maybe some of the audience members may be familiar with. That's a type of cystoscopy where a chemical is instilled into the bladder about an hour before the cystoscope is put in, and then instead of using a white light, or maybe in addition to using a white light, a blue light is also used. And the blue light, when it shines on the CIS after it's been marinated in that chemical, the CIS kind of turns pink, and it makes it a little easier to see. It makes it sort of stick out a little bit, a little more obscure, and so you can see it better. There are certainly cases where it's not seen, CIS is not seen by the naked eye or by the cystoscopic eye by white light, and then is visible with blue light. The excitement about blue light cystoscopy was very high when it first came out, like in the early, like 2010, 2012, 2013 timeframe. Now that we have more experience with it, there's a little less excitement. The long-term sort of survival of patients with CIS in terms of like their recurrent. I mean, the idea was if you were detecting more tumors, the patients would have less recurrences over time. And as it turns out, that's probably not true, or at least there's some evidence anyway that it's not true. I think that probably goes back to this idea that I alluded to earlier about the field cancerization defect of the bladder, where sort of the entire urothelium is just at risk for becoming malignant at any time after someone has been diagnosed with bladder cancer. And so it certainly blue light helps, but how much it helps, I think, is maybe a little more debatable now than it was 10 years ago. In terms of CIS being able to hide in chronic cystitis, I would say yes, for sure. If it can hide in, a seemingly normal bladder, it can surely hide in cystitis, chronic cystitis bladders. And we see that, in patients who have had, multiple bladder tumor resections, multiple urinary tract infections, maybe they have a catheter, the things that cause inflammation in the bladder cystitis, that can certainly mask CIS for sure.
Okay, thank you. And so we've talked a bit about non-muscle invasive disease and some treatments for that. I want to shift a little bit now to talk about muscle invasive disease when the tumor has grown deeper into the layers of the bladder. And we know that one option some patients might pursue or might have is bladder removal. And Tracy, what's the current thinking about patient outcomes for a patient that has chemotherapy followed by bladder removal versus bladder removal only?
Yeah, so these studies are actually now measured in decades old. The initial studies looking at whether adding chemotherapy either before or after cystectomy improves long-term outcomes, and the ones that tested it after had trouble with accrual and essentially never came out to be positive, and the ones that looked before pretty consistently show a modest benefit with the addition of chemotherapy before surgery. I usually quote patients like 5 to 10% improvement, where I can really flip people from not cured with surgery to cured with surgery plus chemo. at, the 5-year mark after surgery. But, the caveat to that is that this is really only chemotherapy that has a cisplatin backbone, which is, a chemotherapy drug that's not always that easy to tolerate, can cause kidney problems. And so you have to have pretty pristine kidney function to get it safely, can cause hearing problems, nerve issues. And so, roughly, at least at UNC, we've looked at our data, just over half of patients are actually able to get the cisplatin safely. And so we can't treat everybody with it. And, the risk benefit, favors chemotherapy, certainly before surgery for most patients. If, we can do it safely, but it's also not a gigantic benefit where people can't get chemotherapy, that they're not going to get cured with surgery, because surgery also cures a lot of people in itself too. So we give it if we can. And then, there's now an approval for immunotherapy after surgery, which at the moment has, delayed time to cancer coming back. And we're hoping will improve sort of survival in general, but that data we haven't seen yet.
And so you mentioned that I think you said only 50% of patients are cisplatin eligible. Can you talk about what would make me eligible or not eligible?
Yeah, I think the number goes up a little bit with time, because I think we're getting a little bit better at managing chemotherapy and a little more aggressive about trying to treat people. The most common reason that people can't get cisplatin is kidney function. So, obviously patients with bladder cancer are at risk of having secondary kidney problems, whether their kidneys are obstructed or, a lot of our patients are older and have diabetes and hypertension and have sort of chronic kidney disease from that. And so that's the most common reason. And then people who have hearing loss, or people who have baseline neuropathy from diabetes, or numbness or tingling in their fingers or toes. And then there's various other things, heart failure. Age is not, really a contraindication. Typically, if someone's is safely thought to undergo cystectomy, typically I can safely give them chemotherapy too. And sometimes I just give them a little bit gentler doses, but sometimes we take that into account with the whole picture too.
Okay. And Phil, on that note, is there an age when bladder removal is too dangerous to do?
I guess so I talk about this sometimes with patients. There's a chronological age, which is how many years old you are, and then there's kind of a physiological age, which is sort of how old you maybe feel. I think I go less by the chronological age and more by the physiological age. So, like, for example, I'm going to use like very extreme examples here, but like, let's say, we had an 80-year-old patient who was really active, maybe, plays golf every day and walks 9 holes or 18 holes and has few medical conditions on one hand. And then on the other hand, maybe you have a 60-year-old patient who's had, a heavy smoker, and they've had strokes and heart attacks and everything, and they both have the same stage of disease. I might feel actually better about taking, someone who's 80 but is in otherwise robust, physiologic age, for a cystectomy, as opposed to like a 60-year-old patient who's been, chronically ill and maybe not in as good a shape. So I don't think I'd put a number on it, but I haven't done very many cystectomies on people who are 80 either. So it's a little bit of again, it's shared decision making. I think all of it sort of goes back to what the patient wants to put themselves through.
Sure. Yeah. And on that note, I'm sure this also varies, from patient to patient and is patient specific, but in general, can you discuss some of the challenges or side effects that a patient could expect once their bladder is removed?
It's a multiple organ surgery, right? We take out the bladder, we hook up the kidneys to a new segment of bowel. So there's a GI portion to this. We work on lymph nodes. So there's a lot of like the preoperative, you're going to maybe have a cystectomy discussion as like a 45-minute discussion that is really, august, kind of a somber thing to put people through, because it's a really big surgery. You're going to have at least one good size incision and maybe a couple of other ones, depending on the way your surgeon does it. There's I don't know, 25 to 50% chance you're going to need a blood transfusion. There's all kinds of complications that happen from, removing organs and putting them back together in an unnatural way. So, those kinds of things are things I focus on when I talk to patients about this. In terms of, the other sort of important, there's sexual dysfunction is a very important thing for patients, especially now when people are more, that's something people care about. And not only do they care about it, but I think it's less taboo to talk about that with their doctor now than it ever has been. So, sexual side effects for both males and females who are undergoing the surgery. And then I think there's also like a very psychological component to this. Like people have, sometimes, body image issues. They're worried about having an ostomy. They're worried about, going to the beach or taking their shirt off in public. Those are all real things. I have patients often don't believe me until they go through it, but I just sort of try to help people understand that you'll sort of get to a point where this becomes your new norm. Instead of going pee, you'll just pee into a bag, or if you have a neobladder or a pouch or something, it'll become your new norm. And after a while, people just sort of forget about it, and it really does become the new norm. And it's less scary once a patient gets used to it.
Okay. And Tracy, for patients who this either isn't an option to have surgery or they're not interested in having the surgery, what is the latest information on bladder sparing protocols for muscle invasive disease?
Yeah, so as an alternative to cystectomy, we commonly use a combination of maximal tumor resection followed by chemotherapy and radiation together. And we know that some patients do really well, actually arguably comparably well to patients who have cystectomies, especially certain tumor characteristics. As Phil was talking about, if you have multiple tumors all throughout your bladder, it's very hard to successfully radiate all of them. And so potentially cystectomy might be a better option, or if the tumors roll invasive and blocking things, sometimes radiation is not a great option. But for some patients, especially those with kind of small focal tumors, results are really comparable to surgery, and you get to keep your bladder. And so, a lot of patients meet with everybody at UNC pretty much with muscle invasive bladder cancer meets with surgery, radiation, and medical oncology when they first get diagnosed. And, we typically will give chemotherapy concurrently, patients tolerate it pretty well. I mean, there's side effects to radiation too. But, some of the issues with, having a pouch long-term are not there, right? We're even, there's some newer data looking at length of radiation that's, decreased from sort of 6.5 weeks to 4 weeks in a lot of patients based on some data in the last couple of years. And so it's not even quite a time commitment as it used to be for some patients. So really, I think it's a good alternative for some patients. There's still the patients that, we relatively strongly favor surgery for if they have certain tumor characteristics. But, for patients that either can't have surgery or for those with good favorable tumor characteristics, I think it's a really great option.
And Phil, for those that do have surgery, are there standards for surveillance post-radical cystectomy, or is it case by case?
No, there's definitely a guideline. So there's a couple of different guidelines. I think the ones that most people use, the ones that I use certainly are called the NCCN guidelines, or the National Comprehensive Cancer Network guidelines. So typically that means, surveillance really for the audience really means looking for the cancer to come back. So in anyone that has a cystectomy, they're hopefully going to have a presumably disease-free interval after their surgery, and hopefully that disease-free interval goes until they pass away from some other cause. But in a good number of patients, the cancer will come back and it will be spread. It could come back in the area of the pelvis and a lymph node, the lungs, the liver, a bone, anywhere. And so that surveillance is important because we think that if the cancer recurrence is caught earlier, getting them from the surgeon's care to Tracy's care to oncologist care is going to help them have a better outcome to get treatment when the tumor's small. So yeah, the sort of general rule of thumb is every 3 months for 2 years, then every 6 months for 2 years, and then every year, thereafter is typically the way the surveillance occurs, or the timing. What surveillance consists of is typically going to be some kind of a scan, usually a CT scan, a clinical evaluation. You come see your surgeon or your medical oncologist, they talk to you about how you're feeling, examine you, etc. And then lab work that's relevant to your other medical diseases.
And Tracy, for patients where the cancer does spread to other parts of the body, as Phil was just mentioning, could occur, what's the best treatment plan once the bladder cancer has metastasized? And does it depend on where the bladder cancer has spread to? So if it's metastasized to the pelvic cavity versus the brain, are we looking at different treatment options?
Yeah, so in the vast majority of cases, once the cancer has spread to other places, it's really what I consider a systemic process. And what I mean with that is it's a cancer that's in your whole body, right? And so occasionally we can see, 1 or 2 or 3 tumors that we can measure on a CAT scan, but inevitably there's cancer cells elsewhere too. And so because of that, typically treatment is targeted at the whole body. And typically that has historically been through intravenous treatment. Now we have, erdafitinib, which is actually a pill. But either way, it sort of goes through your bloodstream and gets all the sites of disease. The brain is a very special place that actually bladder cancer very rarely goes to the brain. If it does, usually we'll handle it with radiation. But other than that, most of the time, we, treat with systemic IV or pill therapy that'll treat all the locations. Occasionally we do use radiation in really rare cases where it's just sort of one spot and it's been a long time, or even surgery, but those are pretty much the exception. The norm is kind of to give systemic therapy, which, historically had been IV chemotherapy, but now there's a whole bunch of, different classes with immunotherapy, and then erdafitinib, which is a pill targeted therapy against those patients Phil was talking about, FGFR3 mutated patients. And then we have these antibody drug conjugates, and the landscape is changing very quickly in which ones we use first and with which one with in combo or without. But most of the time it's sort of chemo.
And that's a good segue to my next question for you, Tracy, which is, for patients that are receiving immunotherapy, are all immunotherapy drugs basically the same, or would you ever switch among them?
Yeah, so it's a good question and a very confusing state, because kind of all at the same time, initially we had 5 different what we call immune checkpoint inhibitors, which are IV immunotherapies approved at the same time, all targeting, either one side of a protein interaction or the other side. And actually the FDA has withdrawn a couple of those. And so now it's basically very similar drugs that have all just been studied in slightly different disease states and therefore have slightly different FDA approvals. Nivolumab we use after surgery for patients with muscle invasive disease, but high risk features like big tumors that have grown into things in lymph node disease. And then pembrolizumab has an approval now in combination with enfortumab as initial treatment, but then also as second line treatment. And then avelumab has an FDA approval for what's called maintenance. So sort of after you get chemo, just to maintain a nice response. And really the reason that these have different approvals is just because the studies were done in different settings, and the drug companies were all trying to figure out where to get their little place where they'd get an FDA approval. And it's very hard to tell if there's actually any difference between drugs. I will say, that Pembro and nivolumab are both anti-PD-1 and have been successful in ways that, atezolizumab sort of didn't meet its primary endpoint. It withdrew its FDA approval. And so, whether there's something to that, these PD-1 versus PD-L1, we're not really sure, but people like to talk about it. I don't typically switch from one to another. There's really not any good evidence that people will respond to one if they haven't responded to another. And typically, our preference will be other treatments that we know work or clinical trials at that point.
Thank you. And I want to end with a question that's not disease specific, but I think many patients probably grapple with and is relevant to any stage or diagnosis. And that's the mental aspect of the diagnosis and of being diagnosed with cancer and going through treatment. And how would you advise a patient, or what would you say to them when they ask, how do I get over the mental hurdle of worrying if today is the day the cancer returns or moves to another part of my body? And either of you are welcome to comment on that.
I can start. It's hard for me to. I haven't had cancer, so it's for me to say, just forget about it is crazy. I mean, I can tell you my own experience with my family. Both my parents had cancer. My mom survived, my dad didn't. My mom, every time she goes for her colonoscopy and for her CT scan, I worry. She was diagnosed in '99. She had a really rough go with chemo and surgery and the whole thing, and then did great, and then had it come back in her colon when she was 12 years later. So that goes back to the question of, should I stop having cystoscopies for my T1 tumor that had happened 10 years ago? Well, she was 12 years out and we stopped doing colonoscopies and CT scans and got kicked in the gut. So it certainly, I having not gone through it myself, but having my mom go through it, I worry. I think it would be inhumane to not worry. And each person is going to deal with that on their own way. I mean, I think my mom just sort of gets quiet. I don't really hear from her for a couple of days before. I know it's coming. We both know it's coming, and I talked to her that night. And you just sort of hold your breath and brace for impact, and hopefully everything will be fine. So I think that's a really tough question to answer. Just from my own experience with a family member, I don't know that it gets any easier. And I apologize. There's not there's no magic recipe.
Absolutely. Thank you for that answer. And Tracy, I don't want to cut you off if you want to contribute to that. I want to make sure we have time to announce our awards as well.
Yeah, I don't want to miss the awards too. I think Phil's answer was beautiful. I think people are not alone, and it is really hard.
Absolutely. Well, as I said, we are coming to the end of our time. I want to thank you both so much for spending this time with us, answering the thoughtful questions that we had submitted by our patients and loved ones, and also just dedicating your careers and expertise to advancing the bladder cancer field in patients' lives and partnering with BCAN. We're very grateful to have your support and to work with both of you. So thank you so much. And before we close, it's my great pleasure to share with you the 2023 cohort of the BCAN Young Investigators. The recipient of our Patient-Centered Clinical Research Young Investigator Award, which is a unique Young Investigator Award focused specifically on outcomes that are important and matter to patients, is Dr. Rishi Sekhar from the University of Michigan. The recipients of our Young Investigator Awards are Jonathan Chu from the University of California, San Francisco, Sean Clark Garvey at the University of North Carolina, Chapel Hill. Catherine Gessner, also at the University of North Carolina, Chapel Hill. And Soonbum Park at Columbia University Medical Center. Congratulations to all of you and welcome to the Beacon family. I now also have the honor of announcing our Beacon of Hope Award recipient. As part of Bladder Cancer Awareness Month, we ask members of the Beacon community to nominate the special someone who served as a beacon of hope and light in their bladder cancer journeys. We received over 120 nominations this year, and from those, we had 3 finalists. Dr. Amy Luckenbaugh, an assistant professor in the Department of Urology and a surgeon at the Vanderbilt University Medical Center. Nancy Parrish, a bladder cancer survivor and the founder of the North Carolina Bladder Cancer Retreat, and Brian Billings, a bladder cancer survivor and the founder of the New York City Bladder Cancer Support Group. Beacon received over 3,000 votes, a record, smashing the previous year, and it is my pleasure to announce the winner of the 2023 Beacon of Hope Award is Nancy Parrish. Nancy is a bladder cancer survivor and the founder of the North Carolina Bladder Cancer Retreat. One of the people who nominated Nancy said of her, she is a bladder cancer survivor herself. Her dedication and love for others is evident from the moment you meet her. She paints and sells rocks to help raise money so that registration for the retreat can cost as little as possible for attendees. You are a stranger only once when you meet Nancy. From then on, you are a friend. Congratulations, Nancy. That brings us to the end of our program. Just a reminder that this will be available for viewing on the beacon.org website. That's BCAN.org in just a couple of days. I want to thank all of you for joining us, and thank you so much to our experts again and for everyone's support of Beacon and our bladder cancer community. Have a good evening.